Thank you for the invitation. My great pleasure to be here. I'm trying to share my presentation. Great. So I'm going to talk about en bloc resection. I'll start with some basic stuff because many of us here may not have tried en bloc resection before. And then I will try to discuss about some challenges that we may need to overcome in the future. So as you all know, TURBT is the conventional treatment for bladder cancer. In fact, it's an operation with a long history, more than 90 years. And during that time, the ability to go through such a narrow urethra to take out a tumor is something really amazing. But then what we observe is that despite a potentially curative surgery for in principle, superficial disease, the recurrence rate is still very high. 1 year recurrence rate on average, 30–40%, 5 year up to 7–8%. And therefore, we have so many different types of adjunct treatments, including installation of chemo, second surgery, BCG, etc., in order to optimize the cancer control. And we need so many repeated cystoscopy in case there's any recurrence. So I thought, is there any problem with the conventional TURBT? I think there are two main problems. First, as we resect the tumor in a top-down manner, in a piecemeal manner, the tumor specimen is being fragmented, and whether a complete resection has been achieved is totally dependent on the surgeon's experience, surgeon's vision. And unfortunately, this is prone to error. And therefore, even nowadays, after a so-called complete resection, in selected cases, say patients with T1 disease, if we go ahead for second surgery, residual disease is quite frequent, up to 30% of the cases. And therefore, second surgery is kind of a gold standard to compensate for the first surgery in selected patients. The second problem is something more theoretical, is that when we resect the tumor in a piecemeal manner, when your bladder is filled up with floating tumors, there will still be some cells inside the bladder, and there's a possible risk of implantation, therefore leading to early disease recurrence. In fact, take a biopsy from each tumor, you send it for sequencing. Previous studies have demonstrated a monoclonal origin, which means that tumor seedling probably occurs. And it's probably true. So this theoretical risk is highly possible. And so en bloc resection has been advocated as surgery to overcome these two main problems. In fact, it is not a very new surgery. It was first reported back in 1980 by Kitamura. And during that time, he used a snare to take out a tumor. And of course, the potential benefits is to avoid fragmentation of tumor, minimize the chance of implantation, as well as having an intact specimen. So now complete resection can be determined by clear resection margin rather than by surgeon's judgment alone. Many different types of energy sources that we can use, electrical, meaning monopolar, bipolar, laser, holmium, thulium. And of course, there's another one called ERBT. Basically, it's a probe which allows injection of saline into the submucosa, elevating a tumor, and then followed by incision of the around the tumor using a monopolar energy. And in my opinion, it doesn't really matter which energy source you use. I encourage you all to try them out and find your own preferred one. And I really think that surgical technique is primary and tools are really secondary, and you just choose your preferred one. That's usually okay. And since many of us may not have the experience in doing en bloc resection, I will just go through some very basic principles. As in all bladder cancer cases, when you put in a scope in, inspection is very important. We often miss tumors which are subtle. But more importantly, for en bloc resection is to determine whether the patients is really amenable to such surgery. It depends on the location of a tumor. For example, For tumors located at bladder dome, it might be more difficult to excise. Number of tumors is something that we need to consider. If there are 10, 20 tumors, and forget about en bloc resection because it's going to take too much time. Size of tumor has long been emphasized as a limitation for en bloc resection, because even if you are able to excise the tumor in one piece, because of the narrow urethra, you may not be able to retrieve it in one piece. So, is there any role if you take it out in few pieces? Is there still any benefits of doing it? And general principles, we usually keep the bladder slightly distended. This is really to facilitate your incision. When it is slightly distended, when you use energy to incise on mucosa, it will easily tear apart. The planes become clearer. It's much more easy to do it. We usually mark the circumferential margin with cautery. My usual approach is to mark it about 5 millimeter from the tumor, from the visible tumor. At least in my experience, with a 5 millimeter type of margin, we're able to achieve a clear margin in about 98% of cases, so I'm happy with it. And then I would strongly encourage you to have a circumferential incision first. Make sure that the whole margin is down to the correct layer. And usually the tumor will shrink in the middle if you have reached the correct layer. And then we will try to dissect or incise the central part of the tumor base, either in a retrograde manner or an antegrade manner. Most of the time, retrograde manner will be easier. It's just a simple case to illustrate the principles. Small tumor over the left lateral wall. For me, I usually use bipolar en bloc resection for various reasons. As I mentioned before, we mark it with cautery. Some people would use collar knives to do it. For me, I prefer to use resection loop, because I think resection loop is like mesenbum scissors. It allows both sharp and also blunt dissection. If you use a collar knife, it's more like a knife, more like a scalpel. And it's a good incision in many ways, but blunt dissection may not be as easy using collar knife. With the bladder slightly descended, and we'll go ahead for the margin, which is nearest to me. I call it proximal margin. I always do it in an intermittent burst type of manner. And then with the bladder being slightly distended, you can see right here that the mucosa tears apart when you incise it. And you can see the overlying tissue, the mucosa, some mucosa, they are mobile. Okay, so everything that moves, that's mobile, they are superficial. And the detrusor muscle, they are below it. They can't. Usually, they will stay relatively fixed. You can see I try to rotate my scope a bit. My loop a bit, so the insulated yellow part is against the tumor. This is really to preserve the architecture of the tumor. You don't want to burn the tumor accidentally. And when I say I try to incise it circumferentially, you can see the tumor actually shrink into the middle. That's what I'm trying to say. And then after circumferentially, then we try to tackle the central part by pushing it. See here? Yeah, the tense up tissue below, you try to tackle it. So most of the time, retrograde manner will be easier. But in locations such as bladder dome or high posterior, you might need to climb over a tumor and go from an antegrade approach instead. If you're doing enough, you'll probably be able to achieve a specimen like this. Always communicate with the pathologist about the advice. They will be quite surprised about it. Pin the mucosal margin for a better orientation, and the pathologist will be able to ink the margins with different colors and then prepare the blocks accordingly. And then you can have a very good assessment at the depth of tumor invasion as well as the resection margin. Okay, these are the basic principles, and of course we may have cases. So this is a case where I thought I'm going to deal with a small tumor, but when I went in, it's such a big tumor. It's impossible to do en bloc resection. And it's really an imperfection when I try to resect the top of the tumor, followed by en bloc resection. So this tumor is at the lateral wall, there's obturator jerk. When I say blunt dissection, this is what I really mean. So you can see I'm pushing the tumor. It's like tearing from the base. this is more or less the same feeling with enucleation in prostate. And in such cases, you don't even need to use energy to take out a tumor. So in fact, when people say en bloc resection, are you afraid of high risk of perforation? In fact, it's a very controlled procedure, and you have ways to tackle a tumor without using energy. So in fact, it's even a safer surgery than conventional TURBT. One thing to take note is that if you decide to do it this way, then your plane tends to get more superficial. It's more like a superficial, it's more like a submucosal type of dissection rather than the conventional deep resection down to the detrusor muscle. In such sense, then you should probably take more tissue from a tumor base just to make sure that your margins are clear. In this case, came back to be a T1 disease, and the second look surgery is negative. And the biggest criticism about en bloc resection is really if you are dealing with a large tumor, and as in the case that I showed just now, I'm not able to take on one piece, then is there still any benefit of doing en bloc resection? So I'm just going to share with you two more cases here. This is a case with a relatively big tumor that doesn't look good on CT. I tried to do en bloc resection. I excised in one piece. I tried every way that I wish to, but then I still can't take out a tumor. And then I have to divide a tumor in few pieces for extraction. And to make it worse, during the resection, I feel that the base was involved by tumor. I thought it was a muscle-invasive bladder cancer, and it was a very frustrating day for me because I spent an hour to do a surgery. I can't take out in one piece, and I thought it's a muscle-invasive tumor, and there's no point, totally no point of doing it. But to my surprise, the pathology came back to be a T1 grade 2 disease. And I realized that my endoscopic judgment of a muscle-invasive bladder cancer is actually wrong. This is also prone to error. And in fact, I can never know whether it's muscle-invasive or not. In such sense, although I am not able to take out the tumor in one piece, at least I'm sure that I've cleared it completely. And the margins are clear. The second surgery is also negative. 2 weeks later, I have a similar case, slightly smaller tumor, better in the sense that during the surgery, I think the tumor base is healthy. And it came back to be TA grade 2 disease. Second surgery is also negative. And therefore, there's a gradual change in the concept. We start to accept modified approach of en bloc resection, meaning, for example, resecting the top followed by en bloc resection of the base, or you do en bloc resection, but then you take out the tumor in a few pieces. Let's just admit it, it's a compromise for bigger tumors. And it's not a true en bloc, so seedling may still occur, but the benefit of ensuring a complete local resection remains. So this is a changing concept that people start to accept. But I still need to emphasize one more point, is that in en bloc resection, when you are aiming for a complete resection, it is a surgery intended for non-muscle invasive bladder cancer. It's not intended for muscle invasive bladder cancer. And therefore, actually, most cases, most non-muscle invasive bladder cancers can be dealt with en bloc resection. In my experience, about 90% of the cases can be dealt with en bloc resection. So I think it's still a relatively good surgery for most patients. This is another case I wish to share. 78-year-old man, BCG intolerant high-grade cancer. When you use white light, you don't see much problem inside bladder, but when you use a narrow band imaging, then you start to see something really wrong. Basically, it's filled with almost like a CIS changes over a large part of the left lateral wall. And given the fact that this case is BCG intolerant, next step may be radical cystectomy, but he's a relatively old patient and he doesn't want major surgery. And he's intolerant to BCG, can't re-challenge with BCG. So I think a good surgery may be able to help the patient. So in this case, it's a wide area involvement, but then it's not exophytic, it's not a sessile mass. So I still do en bloc resection. In fact, a specimen like this, they are usually quite soft. So when you use ALEC to evacuate, it's actually quite easy. And after I removed it, then you will have an overview of how it looks like. So even a big wide area is amenable to this type of surgery. It took me about 1 hour. And in this case, luckily more than a year, he is still disease free. So I hope that this patient is, this surgery really helped the patient. Number of tumors, is there a limit? Well, technically not, but certainly more time consuming. So it depends on experience. It depends on judgment at the beginning of surgery. The maximum number of tries, this case, 7 tumors in the patient. It took me about 1 hour, and I think it's still relatively reasonable. All right, is there any evidence on blood resection? Actually, we just did a systematic review and meta-analysis. There are 10 studies, 10 RCTs on blood resection, but then only 4 have full publications. Most were single center studies, relatively small sample size. What do we know now when compared to TURBT? It's more lengthy, about 9 minutes longer, shorter irrigation time by 7 hours, but more importantly, on-blood resection actually had a much lower rate of bladder perforation, reduction by 70%. The big question is about recurrence rate. Unfortunately, all our studies didn't have good data, didn't have good primary outcome on recurrence rate. So more studies are still needed. In fact, we have a number of ongoing RCTs. We look into clinicaltrials.gov. The first one is actually a multi-center RCT from Hong Kong. We already recruited 310 patients with a 1-year recurrence rate as primary outcome for hopefully in 1.5 years, we're able to deliver the results. We have some other trials using pathological outcome, using second surgery outcomes as the primary outcome. So hopefully we'll know whether this surgery can spare a second surgery in the future as well. So if you are interested in surgery, I strongly encourage you to read this consensus statement, which is just published in European urology, leading experts across the world. And we developed like 99 statements about on-blood resection. If you are really interested, have a look, and hopefully we'll have a better standardization of procedure. I wish to end this talk with this last paragraph in the paper. Although on-blood resection is a promising technique, learning curve of on-blood resection and whether it is easily generalizable is an important issue to address. I think webinars like this are very important because education and training is the key to generalize the procedure, which is potentially helpful. And hopefully, with the foundation of a statement, we're able to standardize the procedure, and we're planning for a prospective study on this as well. It's going to be an international registry type of study on on-blood resection. So long-term real-world data will be important to determine the true value of on-blood resection, but I really believe cancer principles exist for good reasons. So hopefully in the future, we'll have more data to see whether on-blood resection really exists for a good reason. So thank you very much once again. So if you have any questions, feel free to send me an email, ask me, I will be very happy to answer them. Thank you very much.
Thank you, Jeremy. That was very nice. Before we start with stones, I think there are a few questions for you, Jeremy. So are you ready? Can I just ask you those questions on behalf of our participants?
Oh, of course, of course.
All right. So first question they want to know is, what is your bipolar setting when you are doing tumors in resection?
So I use the newer generation of the Olympus bipolar system. So the usual setting for TURBT, meaning 200 for cutting and 120 for coagulation. But in patients where you experience obturator nerve reflex, then I suggest you to try to tune down your cutting mode to about 120. I think it's a good balance between a good incision and a reduction in the obturator nerve reflex.
And of course, the next question is to prevent an obturator jerk. Is there any other tricks that you adopt?
The main tricks is really reduction in the energy, as well as try to incise in the areas more laterally or medially where there's no jerk. And then once you have gotten into the correct layer, then you try to use blunt dissection. So you gradually move to the central part where there is a nerve reflex. And as you know, usually there's just a certain small area where there's a jerk. Once you have passed through that area, then you can start with your incision again. So in my experience, basically it is possible to just do the surgery in any cases with nerve reflex, basically.
Okay, the next question somebody needs to know is, how do you exteriorize very large volume tumors? Do you mosylate them, but we want to preserve the histology, so what do you do for them?
Okay, so because of the time constraint, I actually didn't show those slides. But then there are a few ways.
The brief words, yeah.
First is what I've talked about, modified en bloc resection. Second, some people has been using endobags to help the extraction of the tumors. Thirdly, if you use the morcellated scope, the channel is actually quite big. So some people will use laparoscopic instruments, those small laparoscopic instruments, to go through a channel and have a good grasp of the tumor and then take it out. Personally, I am not a fan of morcellation of a tumor. I think it has a risk of creating more seedling, and of course, morcellation has a risk of perforating a bladder. If it does, then it's a nightmare for the patient.
So the next thing is somebody would like to know, what is the angle of the loop during your en bloc resection, or is there a special loop that you use?
It's just a normal loop. Some people might try to bend it forward a bit. In fact, if you ask the device company, they may have those 45-degree forward angulated type of electrode. I think it really depends on the location of tumor that you're dealing with. Most of the time, it doesn't really matter. The tumors which needs a specific angulation is probably those bladder tumors, where you can try to ask for specialized electrodes. In those situations, probably using a Collins knife or type of electrode is easier than using a loop electrode. I think it takes experience. It really depends on the tumors that you're dealing with.
And for the last one, a comment from the audience which says that if it's a very large tumor, re-resection of the floating fragments would be quite time-consuming and complexly undertaking. So do you believe in giving some wash 30 to 40 times after your resection?
So the whole idea of en bloc resection is really to minimize the amount of floating tumor cells. So in fact, it should be minimized. But I personally believe that seedling occurs. So after en bloc resection or conventional TURBT, I always try to do copious amount of washouts just to make sure that I try to take out every cancer cell away from the bladder. That's what I usually do.
So we simulate in every possible way the same environment as we do in bipolar resection, just using an en bloc methodology. So thanks, Jeremy. I think, sorry, you were saying. Please finish.
I agree. So I think it's a good point, but I don't see bipolar doesn't, well, monopolar bipolar doesn't really matter in terms of seedling risks. En bloc resection is trying to reduce this risk as well, but still, I think washing out multiple times, I think it does help in reducing and possibly reducing the recurrence rate.
Okay. Thank you so much, Jeremy.